Hello, my name is Rubén Palacios, and today we're going to talk about Caplacizumab for acquired thrombocytopenic purpura. The definition: this is a rare disorder that causes blood clots or thrombi to form in small blood vessels throughout the body. These clots can cause serious medical problems if they block vessels and restrict blood flow to organs such as the brain, kidneys, and the heart. There are complications resulting from these clots can include neurological problems, fever, abnormal kidney function, abnormal pain, and heart problems.
Thrombotic thrombocytopenic purpura, or TTP, belongs to a group of blood disorders known as thrombotic microangiopathies, TMAs. TMAs are characterized by clotting in small blood vessels, a reduction in platelets, or thrombocytopenia, the destruction of red blood cells, referred to as microangiopathic hemolytic anemia, or MAHA, and subsequent systemic ischemia. TTP is a rare disease with an annual incidence of 2 to 6 new cases per million people. It is more frequent in females than males, with a ratio of 2 or 3 to 1, and it manifests at a median age of approximately 40 years. TTP is caused by a deficiency in the protein ADAMTS13, a metalloproteinase that cleaves and regulates the size of von Willebrand factor, or VWF multimers. When levels of ADAMTS13 drop, ultra-large VWF multimers accumulate, leading to uncontrolled platelet-rich thrombus formation in small blood vessels. There are two main forms of TTP. Congenital TTP, or cTTP, is due to inherited mutations in the ADAMTS13 gene. Acquired or immune-mediated TTP, in short ITTP, accounts for more than 95% of cases and is caused by autoantibodies against ADAMTS13, which develop with a yet unknown cause. TTP can be triggered by conditions that increase VWF levels, such as pregnancy and inflammation due to surgery, infection, autoimmune disorders, or cancer. Acute episodes of TTP are usually rapidly progressing and often fatal if not diagnosed and treated immediately. Risk factors for mortality include age greater than 60 years, severe involvement of the central nervous system, lactase dehydrogenase, or LDH, levels greater than 10 times the upper limit of normal, and cardiac troponin levels greater than 0.25 micrograms per liter at presentation. Despite the availability of treatment for TTP, a number of unmet needs remain in terms of diagnosis and management. Acute episodes still result in 10 to 20% fatalities, and the disease course may be complicated by exacerbations which occur in up to 50% of cases, and refractoriness to standard treatment. Furthermore, major thrombotic complications that may occur during the first 3 to 5 days of acute events often have long-term consequences for health and quality of life. Recurrence experienced by 30 to 40% of patients is also a major concern.
Caplacizumab is a single-domain bivalent antibody designed for the treatment of thrombotic thrombocytopenic purpura and thrombosis. It was used together with placebo in a study in 65 patients with diversified TTP in two groups. Improvement in the disease were evident with the pharmacological action of this drug that consists in binding to the protein called von Willebrand factor, which may prevent blood clots from forming. However, adverse effects such as bleeding were noted and were mild. The drug reduced the risk of ischemia in the affected organ. Applications in medicine. This drug is an option for the treatment of TTP in adults and adolescents that are more than 12 years old and also who weigh at least 14 kilograms. This drug proved to be effective in the disease, generating good results when it is implemented together with immunosuppressive therapy and daily plasma exchange. During this study, the drug was administered in dose of 10 milligrams 1 hour or 50 minutes before the daily plasma exchange intravenously and after the plasma exchange subcutaneously at 30 minutes. The maximum duration of study drug administration was 19 days in these patients. Now, the benefits. This drug produced the following results: a more rapid resolution of TTP episodes, faster platelet count normalization, also prevents the creation of microthrombi and the consequent progression of tissue ischemia. Also, it inhibits the pathophysiological mediator of the microthrombosis.
We've presented a trial which is a randomized trial looking at a new type of therapy called an antibody. This is a very important molecule which can act specifically, be manipulated to prevent the platelet BWF binding. It was a randomized trial where patients received standard therapy and they either received drug or placebo before plasma exchange was started. And this was continued following plasma exchange on a daily basis for up to 30 days after achieving remission. And remission is defined by normalization of the platelet count.
What we achieved actually was the number of the days for the normalization of the platelet was significantly lower for those patients that they were treated with Caplacizumab. And as a secondary outcome was extremely interesting that because we could see that for 30 days that patients were treated with Caplacizumab, they were protected to have exacerbation. There was few mucosal type of bleeding, but in none of the patients there was a need to use the concentrate to solve the problem of the bleeding. So I would say all over, the drug could increase minimally the mucosal type of bleeding, but not significantly bleeding episode that could create a clinical alteration for the patient to prevent the use of this drug.
The importance of this paper is twofold. Firstly, it's the method of action of the compound, which is really quite unique. It's not associated with significant side effects. It doesn't appear to be immunogenic. The second important, and probably the most important reason for this trial is that we have always been stuck in the acute scenario of trying to achieve a rapid increase in the platelet count, which in itself is associated with a better outcome for patients. And that's exactly what's been demonstrated in this paper.
I think it could have two significant impacts. One is sort of decreasing the dependence on plasma. Despite the advances in immune suppressive therapy, better plasma exchange, better supportive care, the 10 to 15% acute mortality in acquired TTP in an acute episode has not been impacted. I think this has the potential to do that.
For me, the most important thing was, even if I'm working and I'm trying with the PEX to remove the platelet, I'm trying to do the best that I can do at the immune system with the immunosuppressive treatment. But the disease is too fast and I'm not able to achieve the result I want. With this drug, I can control the symptom. I can detach the platelet from ultra-large convalescent factor and not having the consequence damage of this microthrombosis and giving me time to move on with the other type of the facility I have. That is fantastic. I mean, this is, I think.
Pros and cons. The most important benefit that Caplacizumab gives after a faster platelet count normalization. Also, It prevents further consumption of platelets into microthrombin and the consequent progression of tissue ischemia. There are more benefits and also adverse reactions. So, talking about the pros or benefits, we have that to control the pathology of microvascular thrombosis. It inhibits the pathophysiological mediator of the microthrombosis and also resolved of the organ damage markers. It also reduced the number of exacerbations of TTP. Talking about the cons, there are headache, stroke, meal bleeding events, eye bleeding, hematoma, epistaxis, dyspnea, urticaria, myalgia, hematuria, fatigue, bleeding, pruritus, erythema in the injection area. Despite the new outcomes, the mortality remains from 10 to 20%. In some cases, occurs relapse after during the drug administration in the next day or 1 month. Issue applied in Ecuador. It is considered escape technologies in the epidemiological field on this pathology, especially at Latin American level. However, it is estimated that every year about 2 to 6 new cases of thrombocytopenia are detected for every million inhabitants worldwide. In our country, the incidence and prevalence of this pathology in the population is unknown, since the corresponding epidemiological studies have not been carried out. The highest incidence of chronicity are in adolescents. Mortality attributed to thrombocytopenia is low, from 1 to 4%, usually caused by severe bleeding and more importantly by infections associated with immunosuppressants administered with therapeutic intent.
Acquired thrombotic thrombocytopenic purpura is a potentially life-threatening condition caused by an autoantibody to ADAMTS13. Reduced activity of ADAMTS13 leads to the accumulation of ultra-large von Willebrand factor molecules that can bind to platelets and induce aggregation, leading to systemic microvascular thrombosis. This in turn can cause severe thrombocytopenia, hemolytic anemia, and multi-organ failure. Caplacizumab is a nanobody, a single monomeric variable antibody domain that targets von Willebrand factor and blocks interactions with the GP1B receptors on platelets. Investigators conducted a phase 2 single-blind study at 56 sites worldwide, randomizing 75 patients with acquired thrombotic thrombocytopenic purpura to receive either caplacizumab or placebo, in addition to standard of care treatment, daily plasma exchange, and immunosuppressive therapy. As compared with standard treatment plus placebo, standard treatment plus caplacizumab reduced the median time to recovery of platelet counts. Exacerbation of thrombocytopenia within 30 days after the end of daily plasma exchange was also less frequent with caplacizumab, but bleeding-related adverse events were more frequent in the caplacizumab group. Thus, caplacizumab induced a significantly faster resolution of acute acquired thrombotic thrombocytopenic purpura than did placebo. Full study results are available at nejm.org.
Conclusion. In conclusion, the treatment of acquired TTP with plasma exchange and immunosuppressive therapy takes time to achieve resolution of this disease. And even when patients have a response to therapy, they are at risk for further microvascular thrombosis, which is unpredictable in its onset, severity, and outcome. With the option of Caplacizumab in this disease, it's possible to improve the symptomatology and state of the patient. Though rapid blocking of von Willebrand factor mutated platelet aggregations prevents further platelet aggregations more rapidly than conventional treatment alone, which could potentially prevent short and long-term in organ injury due to ischemia. Thank you.